test. We would like to ascertain all members can hear this recording. Please respond. We will begin. Welcome. The Institute for Evidence-Based Care is pleased to offer this webinar, Current Evidence in Smoking Cessation. Continuation credits are available for this offering. Participants must remain for the entire session in order to claim continuing education credits and complete the appropriate session evaluation for physicians or nurses found originally on the website and fax it to the Institute for Evidence-Based Care at 732-776-4837. Give you your certificate upon completion of the evaluation and that you provide us with the contact information to return that with. Credit statements, a few notes from this page. One nursing contact hour will be provided by the Meridian Ann May Center for Nursing, which is an approved provider for continuing education for nursing by the New Jersey State Nurses Association. Meridian Health is also accredited by the Medical Society of New Jersey and will designate this live activity and the recorded version for a 1.0 AMA PRA Category 1 credit. There is commercial support for the activity, and the speakers have declared that they have nothing to disclose. The program is free of bias. Few details. This webinar is being recorded and will be available for viewing for at least the next 6 months via the original webcast site that you used to access the program. It will be available online 24/7 throughout this time. Continued availability will be announced through the Internet. Please encourage your colleagues to complete the webinar. Additionally, within a few weeks of the presentation, it will also become available on the permanent new site, www.meridianiebc.com. Availability will be announced as well through the intranet for this offering. This makes it more accessible as it is available for easy access through either YouTube or Media Play formats. We will not have time for questions today, but if you have any for our expert, please send them through the webcast itself to the Institute or email Kathleen Russell Babin, and we will ensure that you receive a prompt response. Now to introduce our speaker for today. We are pleased to announce that Dr. Kenneth Kronhaus has become our speaker for this webinar. He received a doctorate of medicine from Ross University School of Medicine in 2002, board certified in family medicine in 2006 by the American Board of Family Medicine. Dr. Kronhaus completed his residency in family medicine at JFK Medical Center in Edison, New Jersey. In residency, Dr. Kronhaus was recognized as a leader in medical education and awarded Resident Teacher of the Year by the Society of Teachers of Family Medicine. He is a member of the American Academy of Family Physicians, the American Academy of Anti-Aging Medicine, and the Institute of Functional Medicine. Kronhaus is a member of the medical staff of Ocean Medical Center in Brick, New Jersey, and as well has privileges at several local nursing homes and assisted living facilities. He serves as a physician advisor to the Ocean Medical Center Case Management Department. Pleased to have Dr. Kronhaus presenting today on current evidence in smoking cessation. Thank you, Dr. Kronhaus.
Thank you, Kathy. What we're today is the most appropriate pharmacotherapy for nicotine dependence, and to conduct productive counseling sessions, learning to maximize payment for treatment and counseling. We're going to learn about making some system changes, and we're going to show you some ways to access some online resources. Now, physicians generally undertreat smokers. About 84% of physicians surveyed ask about smoking. About 86% of those that asked advised patients to quit, but we can see that very little is actually done in the way of treatment. Only about 30% recommend a medication and 17% recommend follow-up. Only 7% refer to quit lines. That's pretty poor results, actually. Some clinicians ask. Most of the clinicians, most of us are quite busy in our practices. We don't feel maybe that we have very much time. There's very much financial incentive, and maybe we think that smokers can't or won't quit, but most of this stuff is really not true. Smokers want to quit on some level, but some won't succeed without some intervention on our part. More than 9% we see relapse after an attempt to quit, but using evidence-based programs can more than double the success rates. Now, clinicians are crucial to successful smoking cessation. And who's a clinician? Clinicians are considered physicians, mid-level providers like nurse practitioners, physician assistants, as well as the nurses and other staff that provide care to patients either in an outpatient and an inpatient setting. Brief tobacco dependence treatment is effective. These should be offered to every patient. Now, what is intervention? A brief intervention lasts less than 3 minutes and actually carries strength of evidence recommendation of A, which is the strongest evidence to support change in the patient. Tobacco users should be offered at least minimal intervention. What we find is that repetition is helpful in increasing motivation and the likelihood of future success. Even when patients are not willing to make an attempt, we should continue to reinforce quitting as time goes on. Now, brief interventions don't have to be delivered by physicians. They can be delivered by any of the providers that I mentioned before. EOS can also help increase interventions in the office with automatic prompts and electronic databases of smokers in the practice that can help you to provide other resources, perhaps mailings or calling systems if you have that available to you through your EMR or through other resources. There's also the Ask and Act campaign through the American Academy of Family Physicians. So what should you do? Ask and act. Ask every patient to quit and provide them with treatment tools to help them be successful. And we're going to go over those treatment tools shortly. The first tools that we have in our toolbox is pharmacotherapy. Who should receive it? Everybody. Evidence does not show that meds really help smokeless tobacco users or light smokers. However, if you smoke more than about 10 cigarettes a day, evidence has shown that offering pharmacotherapy is effective. What are pharmacotherapies? First-line treatments are medications like bupropion, nicotine replacement therapy such as the gums, inhalers, sprays, patches, lozenges, as well as varenicline. To consider when you prescribe. Clinician familiarity with medications. Doctors are creatures of habit, and they tend to stick with what they know best. Contraindications also should be considered. Patient preferences, previous patient experiences, as well as patient characteristics like history of depression, psychiatric disorders, and weight gain concerns. Now, pharmacotherapies that we discussed before, most of them either work on norepinephrine, serotonin, or dopamine receptors, as well as nicotine receptors, and portions like bupropion and varenicline. They do work as antidepressants as well as smoking cessation aids. And one note should be that antidepressant class medications can lead to some possible psychiatric complications. These show that nicotine replacement also carries some risk as well, so use caution in the psychiatric population. Always make sure to mention the possible side effects to your patients and have them contact you as soon as possible should they experience anything. The first one we're going to discuss is varenicline. It's also known as Chantix. Its cost is about $4.90 to $5.18 per day. These are most recent pricing within the last year, and you should also, with this medication, plan a quit date approximately 1 week after starting the medication. Common side effects are nausea and vivid dreams, and you should monitor for psychiatric symptoms. Now, some people are going to say they can't afford the medication. And my answer to that is, well, if you're on the medication and you've quit smoking, you'll have a few dollars left in your pocket every day after you've paid for the medication, because the price of a pack of cigarettes now in this area is somewhere around $7 to $8 per pack. And if you're smoking a pack a day, you can understand the savings. In some areas, it's even as much as $10 or more per day. Group 1 SR goes from anywhere from $3.50 to a little under $8 a day. This medication is usually dosed at 150 milligrams a day for 3 days, and then you work up to twice a day for up to 6 months. Plan to quit 2 weeks after starting this medication, and common side effects include insomnia and dry mouth, and also watch for psychiatric side effects. Main replacement products like nicotine gum, nicotine inhalers. Common side effects of these things include throat irritation, dry mouth, and cough. You can see as we go through the prices of the individual products, we're just going to move through some of these slides. The most common thing that we see available on the market that most people tend to use are the patches and sometimes those inhaler or smokeless cigarettes. Move along. Some of the nicotine side effects that we discussed are some sleep issues, especially if you put the patch on at night, some skin irritation and nausea after applying the patch. Patients also have expressed nightmares and extremely vivid dreams after starting with the nicotine patches. Using the patch, if you're smoking more than about a pack a day, you should start the patient on 21 milligram patch for the first 4 weeks. But if they're smoking less than about a pack a day, you can start them on the lower dose of 14 milligrams and then work down to the 7 milligram patch. We're going through a little bit further here to second-line therapies. This is off-label use for these two medications. Clonidine is an alpha-2 receptor agonist and acts centrally also as an antihypertensive. You need to watch out for blood pressure changes with clonidine. Nortriptyline, which is also which works on the norepinephrine and serotonin system, but as with bupropion, we don't really know exactly what the smoking cessation mechanism is. Pharmacotherapy for light smokers, like we talked about before, medications have not really shown to be beneficial to light smokers, but counseling is effective in encouraging them to quit. Despite lower consumption levels, light smokers are at risk for developing smoking-related diseases, and light smoking is becoming much more common, probably due to smoking restrictions in the public, as well as the increased price of cigarettes. So these people need to be addressed as well. For patients concerned with weight gain, bupropion and nicotine replacement therapies may delay but usually don't prevent any weight gain. The average weight gain from tobacco cessation is about 10 pounds and more common in women than in men. With past history of depression, you want to work with the bupropion, which is first line, which is also an antidepressant, more commonly used for that disease class, as well as the nortriptyline and the nicotine replacement medications. In patients with significant mental illness like schizophrenia, bipolar disorder, they're going to need medication in most cases. They're also going to likely need higher doses and longer treatment courses, and I would avoid antidepressants in the bipolar disorder, as this could provoke a manic episode. Try to stick with nicotine replacement in this population if you can. Of course, we monitor the psychiatric population closely during treatment. Stopping tobacco can also affect or alter the effectiveness of some of the antipsychotic medications. They may need dose adjustments, and they should discuss this with their psychiatrist as well as the practitioner that's helping them to quit. For patients with cardiovascular disease, nicotine replacement therapy has not shown to have any significant acute cardiovascular events, either in the short term or the long term. And the risk of complications from smoking far outweigh any risk from complications from stopping smoking. Pregnant smokers. Counseling is obviously the best choice. In pregnancy, you obviously don't want to put in, you don't want to give the pregnant smoker, or you don't want to give the pregnant patient any medications if you can possibly help it. However, Brion and varenicline are both pregnancy category C, which means that there isn't sufficient evidence to support or to urge against giving, and more studies need to be done. Replacement is category D in pregnancy, which is discouraged. However, the risk of birth defects from smoking may be higher than the risk caused by nicotine replacement therapy if that's what you really need to go with. Also, of course, discuss this with the patient's obstetrician if possible. Nicotine replacement is shown to be safe. There's not much evidence to support their medications in this population, and long-term pharmacotherapy is helpful with smokers with persistent withdrawal symptoms from the medications. I recommend treatment for at least 6 months, but at least 3 months, but 6 months is better. The patients seem to be able to get over the urge to smoke at 6 months versus 3 months. I think they have a better chance of failing therapy. Combining medications. As with most therapies, combining medications provide synergistic effect and may be more effective at times than either alone. However, don't combine varenicline with nicotine replacement therapy. That's not recommended due to possible interaction. Counseling. Counseling and medication is far more effective than for smoking cessation than either medication or counseling alone. This is strength of evidence A. Patient unwilling to quit should be counseled repetitively on visits. Using petitions for these patients will help to increase their chance of quitting in the future. Continuing and educating them as often as possible. The patient with educational materials and positive feedback, such as talk about their success in the past with quitting, giving them information on quit lines, change their smoking patterns, like not smoking at home, asking the patient to share his or her ideas about quitting smoking, and showing them what happens to them if they quit smoking now. There's an interesting and detailed page in the Eye on Evidence put out by Kathleen in the Institute for Evidence-Based Care that you'll have access to via the internet, intranet as well. On page 2, you'll see what happens when you stop smoking. Within hours, carbon monoxide levels fall to those of never smokers. Within days, the sense of taste and smell return. A couple of months, the symptoms of chronic bronchitis improve. Within about a year, you'll see patients with mild to moderate COPD have improvement in lung function. 4 years, you'll see substantial risk reduction in coronary artery disease patients compared with persistent smokers. Then about 5 years, you'll see decline in lung function that's close to that of never smokers, and cervical cancer risk falls to that of never smokers. 5 years, lung cancer risk reduction is apparent compared with persistent smokers. Within about 15 years, laryngeal cancer risk is reduced by 60%. Within 20 years, lung cancer risk is greater than 70% lower than those for persistent smokers, as well as oral cancer reaches the risk that is equal to that of never smokers. It's a fantastic page and makes it very apparent for the patients how they can improve their health by stopping smoking. To quit, intensive tobacco dependence treatment is far more effective than brief treatment. These patients are primed and ready to go. Intensive treatment lasts for more than 10 minutes per the CPT guidelines, and I would schedule patients specifically for tobacco cessation visits, reinforce the positive health benefits that we discussed before that they can gain from stopping smoking now. Intent treatment should include some problem solving and skill training, as well as social support through your office, as well as through family members. This is strength of evidence B. And individual group and telephone counseling are also effective, strength of evidence A. Social counseling includes avoiding dangerous situations, including alcohol, stress, and being around other smokers. Simply not smoking in the house or having the family members not smoke in the house is really just not enough. Develop a quit plan. Patients should set a date to quit. I recommend choosing a special day like a birthday, anniversary, or a holiday. If none of those exist in the near future, then make a special day to quit. Invite friends that don't smoke, obviously, and tell the family, tell the friends to remove tobacco products from the house. Identify social support and get them started on the medication with detailed instructions before. Now, adolescents. Counseling is shown to be more effective in treating adolescents than medications. The strength of evidence B. One thing we should note with the adolescent population, we should respect their privacy. If you don't, you lose their trust and lose a chance that they will listen to you. Patients with mental illnesses. This is critical to success in this population. More and longer sessions may often be necessary. Work with their psychiatrist as well. Quit lines are also extremely helpful. They're very easy to use. It only takes about 30 seconds to refer a patient to a toll-free quit line. They're staffed with trained individuals that are highly adept at smoking cessation counseling, and it can significantly increase their chance of successfully quitting. Advantages of quit lines, they're very accessible. Patients don't have to wait for classes to form. They don't have to worry about transportation, and they're good for patients in remote areas. The quit line in New Jersey is 1-800-QUIT-NOW. Our quit line referral cards that are available through the American Academy of Family Physicians. You can go to askandact.org for information. Of note, for a time, this 1-800 was only available to the Medicaid and uninsured population. However, at this time, it is open to all residents of the state of New Jersey now, so nobody is excluded. System to identify and document tobacco use status. We are working to change our systems to be more efficient in healthcare. You should include smoking cessation, or sorry, you should include smoking status in the chart in a very easily accessible area like the vital signs area. You can use reminder prompts if you have an electronic medical record. You can use reminders on paper charts like stickers, and these prompts have been shown to significantly increase the likelihood of clinician intervention, and that is strength of recommendation, or strength of evidence A. Let the patient know that you can help them. Have patient education materials handy. Have your staff in your office or in the hospital counsel patients as well. So this type of intervention, all these interventions, the counseling interventions, don't need to be done by a physician. They can be provided by mid-level providers, physician assistants, nurse practitioners, as well as medical assistants and other staff in the office and on the floors. Group visits are also have shown to be helpful, and they are reimbursable by some insurance companies. So, speaking of reimbursement, how do you get paid for smoking cessation counseling or treatment? Well, Medicare pays for tobacco cessation counseling for patients who smoke and have a tobacco-related disease or whose therapy is affected by tobacco use. Well, whose therapy is affected by tobacco use? Everybody's. All Medicare patients who smoke are eligible to be billed for providing treatment. Over-the-counter treatments are not covered, but prescription drug benefits and most plans do cover some sort of medication for smoking cessation. 8 to 12 visits are allowed per year, and they should be intermediate cessation counseling sessions of 3 to 10 minutes. Greater than 10 minutes is considered intensive counseling, and there are some codes they'll show you that you can use to bill for that. Count less than 3 minutes is covered under your particular evaluation and management code that you're providing for the day. For Medicare, the CPT, actually for any insurance company, CPT codes can be seen above. Don't forget to use a modifier 25 if you're billing these codes with another evaluation and management code, and the typical ICD-9 code is 305.1. You see, qualified provider eligible to bill Medicare can bill for these codes. Providers, most insurers provide some coverage for some counseling tobacco cessation. They also most provide coverage for medications for tobacco cessation as well. Each patient has to pay for the medication out of pocket. They tell them they're going to save money anyway, no matter what. For Medicaid, 24 states cover individual counseling for tobacco dependence, and you can go to your state's Medicaid website to find out what they provide coverage for. And 22 states pay for group counseling. So let's summarize some of the recommendations in the clinical practice guidelines. Number one, chronic disease, tobacco dependence is a chronic disease, often requires repeated intervention. Number two, it's essential that the healthcare system consistently identifies and documents tobacco use and treats every tobacco user seen in any healthcare setting. Clinicians encourage every patient to quit, willing, and those that aren't, and use counter treatments and medications that are recommended in the guidelines. Tobacco dependence treatment is effective. We've seen earlier in the presentation the evidence definitely supports providing treatment and counseling in the office, as well as in the hospital setting. Clinicians should, for every patient who uses tobacco, at least a brief treatment in the healthcare setting. Individual and group and telephone counseling sessions are effective as well. Clinicians encourage the use of medication for all patients attempting to quit smoking. It's medically contraindicated, as we've discussed before. We went through medications that reliably increase long-term abstinence rates, and they can be seen in the slide. The combination of counseling and medication is far more effective than either one alone. Quit line counseling is effective with a diverse population, and it has a very broad reach. It's very easy to obtain, very easy to refer to as well. If a user is currently unwilling to make a quit attempt, clinicians should continue to use motivational treatments, continue encouraging quitting in the office. This has been shown to increase effectiveness of future quit attempts. The tobacco dependence treatments are both clinically effective and highly cost-effective relative to interventions for other clinical disorders. Insurers should all be encouraging their patients to smoking and provide reimbursement for that. Prevention: if we meaning healthcare professionals advise 90% of our patients to quit and offer them medication for other assistance. We can save 42,000 additional lives each year. Right now, we're only offering this to about 28% of patients. It's pretty. We need to fix that. The next slide here is the Ask and Act campaign by the American Academy of Family Physicians. They provide referral cards that you can order. They're bilingual. There's lapel pins. There's other handouts. There are smoking guides that are available there. There are patient education materials as well that are also multilingual. There's also a pharmacologic product guide that's available that you'll also get within the Eye on Evidence handout that will be available. These include dosing information, pros and cons and side effects for nicotine replacement therapy, bupropion and varenicline. Recently updated to include the more recent varenicline warnings regarding the psychiatric or psychological side effects, and the cost per day for each medication is as up to date as possible. Information on tobacco group visits, and there are also other tobacco cessation webcasts, podcasts that are available through the Ask and Act campaign, and you'll also be able to watch this presentation on demand via the intranet in the future as well. There's all My Time to Quit page. The web address is there. There's some good information there for helping patients to stop smoking as well. And that pretty much covers the extent of the evidence, current evidence for smoking cessation.
Thank you so much, Dr. Kronhaus. That was a very informative session, and thank you all for joining us. I wanted to point out a few important key points in the current issue of Eye on Evidence. We found it very interesting to see a few key facts come on our review of the literature. Was that one study of British doctors found that a loss of 10 years of life expectancies was seen with smokers compared to non-smokers. And from that, they deduced that quitting is truly helpful at any age, and that gains in life expectancy can vary by age of cessation, of course, but can even range from 3 years at 60 years to 10 years at 30 years. So there's good reason to stop. I saw newscasts in the last month where they were speaking about how many children start smoking every day. This figure has been estimated just under 4,000 children and adolescents smoke their first cigarette every day in the U.S., a rather alarming statistic for us all.
Definitely.
Attempts at cessation are unfortunately going to more often fail. The actual evidence-based guidelines that Dr. Kronhaus has offered to us allow us to give the smokers a chance. Without them, they will undoubtedly have a much lower chance. I'd like to take a moment and emphasize that quit line. Very excited news from the Department of Health. We gave them a call, and they confirmed that indeed the quit line availability has been expanded, and that it is available to all New Jersey citizens. You can actually have 5 calls covered for yourself in getting support for smoking cessation through New Jersey Quit Line, and I encourage people to recommend using that. It's a new accessibility made available through CDC funding. And you will find a variety of other additional materials in the Eye on Evidence. Both this session today and the Eye on Evidence do carry CME. Reminder, participants must complete the appropriate self-evaluation found on the website and fax it to the Institute for Evidence-Based Care at 732-776-4837 with your contact information so we can be sure to return your certificate. Content on smoking cessation is shared on the intranet, and if you go to the Institute area of the dashboard, you can find our materials there as well. Look forward to our next webinar, which will be Current Evidence in Pharmacologic Management of Diabetes, presented by Katie Militello, PharmD of Jersey Shore Medical Center. That will be May 30th, 2012, and we look forward to seeing you again at our sessions. Thank you for being with us today, and thank you again to Dr. Kronhaus for a great presentation. Have a good day.
Thank you.